more sexually active high school students are using long-acting reversible contraceptives, which prevents pregnancy, but they're not preventing sexually transmitted infections.
The whole point of this whole article was to bring awareness to primary care physicians and physician's assistants, but I think it's applicable here because I don't think most hygienists, dentists have this discussion with their patients about the association of HPV with oropharyngeal cancer. I think it's lacking.
With a little bit of experience and a little bit of focus on the patient, we can become very accomplished in this role of taking a sexual history.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of Tale of Two Hygienists. This is your student roundtable,
which is brought to you in part by Q Optics and Elevate Oral Care.
Yeah, the student roundtable that we started last year, 2019, that was kind of your little brainchild there, and then I revamped it here in 2020.
Upgraded.
I don't know if it's an upgrade, but we started doing this because we really wanted to engage the students. We know that you're taking a lot in while you're in school, but there's a lot more to know about dental hygiene and how do we actually apply it in an office as an actual hygienist. And so we are doing something really fun this year where we're looking at research, but hopefully not in a boring way.
Yeah. I mean, good conversations. We're going to have some experts in there bringing like real applicable science to it. But yeah, definitely not in a boring way. Like it's conversations. It's the stuff that you hear on all of our other episodes.
Well, what I think is so great about evidence-based dentistry, in reality, evidence-based dentistry should be the patient, the clinical experience of the clinician, and the research. And so that's what we want to bring to you is what is the newest research on a specific topic? And then how would we apply that to, because who the patient you see is a little bit different. Their needs, their lifestyle, their socioeconomic background, it's very different than mine. But the research says this. So how could we apply that research in our particular practice?
Absolutely.
And that's what this is going to be about. So we'll have guests on, we'll talk about that and tell you how you can apply it. Maybe even bring it to your fellow students or your cohort or as a project in your school.
Similarly, though, also, if you have suggestions for things that you are already looking forward to just past graduation, you want us to answer those questions, we'd be more than happy to do some research for you. So make sure you guys are reaching out to us.
Yeah, always reach out to us. Definitely follow us on Instagram. Subscribe to our newsletter. You can head over to our website at taleoftwohygienists.com and reach us that way. And we very much look forward to your feedback and also being a colleague of ours one day.
Yes.
So before we get into the roundtable, I just wanted to give a quick plug for Q Optics. Yes, they are sponsoring the show, but I also want to let you know how easy it was to work with them. We met with them in Chicago at one of the big conferences called Chicago Midwinter. And right there on the exhibit hall floor, they walked me through all of the necessary steps to be able to get really dialed in for a good pair of loupes. Now, I've always been skeptical of loupes, and my experience with Q Optics really changed my point of view on loupes. So if you're thinking about it and you have the ability in the program that you're in to have Q Optics come in, make sure you guys reach out. You won't be sorry.
Hey, Michelle.
Yeah?
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
Listeners, welcome back to another student roundtable. I am really excited that this is going to be the Kickstarter of our Oral Cancer Awareness Month on the podcast, Oral Cancer and Oral Pathology. And I really wanted to focus on HPV for this particular roundtable. So I'm really excited to have three super smart ladies on this podcast. Such an honor. I'm going to have them each introduce themselves, and we'll start with Spring, then Kathryn, and JoAnn. So Spring, welcome.
Thank you. I'm so excited to be here. My name is Spring Hatfield. I've been working in dentistry since 1996, but not all the time in hygiene. I did assisting and other things prior to becoming a hygienist. The most exciting thing in my life is that most of it has been in dentistry. I don't have anything more exciting to tell you about myself.
Well, welcome.
Thank you.
And Kathryn?
Hi, I'm Kathryn Gilliam. I'm not going to say how long I've been in dentistry. I won't say the year, but I'll say at least actually just over 30 years. And I love it. I still love it as much now as I did the day I graduated from hygiene school. I am a practicing clinician still. I'm an author, a speaker, and a clinical coach and consultant. I have my own company called PerioLinks, and I have the honor also of consulting with the Productive Dentist Academy. So I have lots of opportunities to make a bigger ripple in the water and change a lot of lives. It's super exciting for me to help other hygienists elevate their standard of care. And I get really jazzed by that. So thanks so much for having me on. I'm excited about today.
This is great. And JoAnn, welcome back.
Thank you, Michelle. And hi, everyone. I'm JoAnn Gurenlian. I am a graduate program director for the Department of Dental Hygiene at Idaho State University. And I have been a dental hygienist for 40 plus years and love being part of this fabulous profession. My joy is teaching general and oral pathology, among other subjects. And I am a speaker as well as an author, and I've worked in medicine and dental hygiene practice for many years. I teach a course on how to talk to our patients about HPV. So this topic thrills me to no end, and I can't wait to engage with all of you in this particular topic because I think it's a challenging one for all of us and an exciting one. So I can't wait to get started.
Man, so as you guys are giving me your intros, I was just thinking on this podcast right now, I just hit 20 years. Spring, you're hitting almost 25 years. Kathryn's 30 plus years. JoAnn's 40 plus years. Like it's so great that there's such a diversity of years in dental hygiene, but we're all super excited and we still love what we do. And now we're talking to our new generation and future colleagues. I just love this.
It's awesome.
So I'm going to start. I know. So I'm going to start with Kathryn, and you're going to bring to us an article and tell us why you chose that and what suggestions would you have based on this article when we're applying it to patient care.
Okay, I'd love to. I chose an article that's actually a review of many studies that have been done, and this one's called A Review of HPV-Related Head and Neck Cancer. It was published online in August 2018 by Kobayashi et al. And what I do when I look at a study that I'm going to share with my attendees or my coaching clients, I boil it down to the simplest, most relevant information. When I first started lecturing, I used to give all the details about the methodology that they used and the definitions that they used and how they chose their samples and all of those things. And I started realizing that my attendees' eyes were glazing over. And I feel that if they trust that the person who's sharing that information with them has vetted the article and made sure that it is an appropriate source for us, that they really do just want to know the bottom line, tell me the basics and how it applies to me clinically. So that's what I tend to do. And so what I found, the bottom line here is this paper is a review of multiple studies, of course, and they show that the highest risk HPV, which is HPV 16, accounts for 90% of HPV positive head and neck squamous cell carcinomas. So that's so important to us because just because somebody has HPV doesn't mean they're at higher risk unless they have one of the 14 high-risk strains. And we know HPV 16 is the highest risk. We do have the ability now to test for HPV in our offices. And that's probably a topic for another day, but it is an interesting topic. And we know that we all, I believe 90% of us encounter HPV at one time or another in our lifetimes and probably multiple times. And most of us have strong immune systems and we clear that virus and we never even know we have it. But sometimes there's a glitch in the system, and that's what I tell my patients too, And when that happens, our immune system isn't able to fight it off. And that's when it becomes a concern for a possible cancer. So the type of HPV is very significant. In this article, they talk about how HPV negative carcinomas decreased 50% from 1988 to 2004. And those are the cancers caused by alcohol and tobacco. But HPV positive squamous cell carcinomas increased 225% during that same time period. So it's quite significant, and we need to be talking to our patients about it. Several of the studies have shown that HPV positive oropharyngeal carcinomas are highly susceptible to radiation and chemotherapy, and therefore it has a better prognosis than the alcohol and tobacco types of head and neck cancers. So while the incidence is increasing, the prognosis is better. So there's the silver lining in that dark cloud of HPV. So it's really important to differentiate what type of HPV our patients have. And an article of mine was just published. I think it came out yesterday. I haven't received my copy yet, but it's in Dental Entrepreneur's Winter edition, and it's called Yesterday's Protocols Don't Work for Today's Oral Cancer. And that's because our previous oral cancers, the tobacco and alcohol types, were generally found in the oral cavity, the lateral borders of the tongue, the floor of the mouth. It was so much within our visual field. And at that time, I noticed my coaching clients, like myself, way back at one point in time, were mostly focused on the intraoral part of a cancer screening. And now it's so critical to perform the extraoral head and neck exam because these cancers in the oropharynx are beyond our visual field very often. And so that tactile exam becomes critical. Additionally, our questioning of the patients is critical. So if we're talking about HPV-related head and neck squamous cell carcinomas in the oropharynx where we can't see, then we need to ask our patients. We may not feel anything in our tactile exam, but we have to ask if they are noticing that they feel a lump in their throat or difficulty swallowing or hoarseness. All of those questions become very significant when we're talking about HPV-related cancers, and those are going to be by far the majority of the cancers that we'll encounter now in our practices. So I think that's really important, and what's most important also is that clinicians recognize that the age group that we're talking to used to be men over 60 who used alcohol and tobacco. That was the highest risk group. And now we're talking to people as young as 14, 15, maybe 12 years old. If they're sexually active, those people, whether they use alcohol or tobacco, are at risk. And so I'm so glad to hear that JoAnn's teaching a course on those communication skills because I wanted to talk about that today as well. It's so challenging for most of us to bring up that conversation, but we have to because those young people are at risk. And I went and dug a little deeper into some of the statistics. And what we're finding is that more sexually active high school students are using long-acting reversible contraceptives, which prevents pregnancy, but they're not preventing sexually transmitted infections. Also, among sexually active teens, 16% of females and 10% of males reported that they used no form of contraception or protection the last time they had sex. So, they're really playing with fire. I don't know how better to say it.
Sorry, I just made a gross face and I'm sorry. Oh, that's so gross.
Scary,
People, right? Get it together.
Yes, condom use has declined.
I just can't believe it.
I know. It's really frightening, and we could go off on a big tangent about sex education in schools, but that's probably a topic for another day. I feel pretty strongly about that. Condom use has declined 13% since 2007, and yet kids are more sexually active, or those that are sexually active, have more partners. That's actually the way that works. So young adults age 15 to 24 contract about 10 million new STIs a year. 40% of teenage girls between the age of 14 and 19 have had at least one sexually transmitted infection. And that's really eye-opening. It caused me to pause. I thought that was very sobering. And I think about all the teenagers that I see in my practice. I've been talking about this for a long, long time, and we need everybody to be talking about this with their teens. The risk is very high. Half of all new sexually transmitted infections are found among youth aged 15 to 24, even though they represent only a quarter of the people who are sexually active. So that's an eye-opener too. They're getting half of the STIs that are happening, and it's because they're not using protection. They're not using condoms, they're not using dental dams, and they're not practicing abstinence. So they're opening themselves up literally to terrible risk. And we need to talk to our patients about that. I had a great experience myself. I've been talking for a long time to my patients and getting permission from parents. I have only had one parent refuse that conversation. And most of the time, the parents come in the room with me. Sometimes they choose not to, and that's okay. But I think people realize that if we open this conversation, it makes their further conversations easier. We open the door to that. And that's what I want clinicians to hear from this, that our young adults are at terrible risk, and it's our responsibility to protect them and to educate them. So that's what I do. And last week on Tuesday, I had a 16-year-old come in, and her mom came in, and I started to talk to her about her risk as I was performing her head and neck exam. When I start the exam, I start talking about risk. And so at that time, I asked the mom if I could go into detail, and she said, absolutely. So I started talking about the fact that this girl was at increased risk for head and neck cancer because of the human papillomavirus. She asked questions about how she would be at risk, how she would contract that virus. I talked to her about unprotected sex. I talked to her about oral sex. I talked to her about methods of protection. And mom was fully supported. And I just felt like what great timing this was, because 2 days ago, I was doing a workshop for dental hygienists, and we talked about that. And today, I have the opportunity to talk on this podcast about that. And I certainly want to make myself available to anyone who has questions about scripting, about how to have those conversations. I'm available to role play with you and share what I say. But for me, that was the most important takeaway from that paper, is the incredible increase, 225% increase in incidence of HPV-related cancers, and the age group of the people who are most at risk. It's heartbreaking to think that the youth of America and probably the youth around the world are at such high risk for this deadly disease.
Wow. Thank you for sharing that. Spring or JoAnn, do you have anything to follow up with?
No, I mean, I can contribute. I agree with everything she has said, and I've really been excited about everything that you have talked about, because I've been nodding my head the whole time going, yes,
I know,
I'm so
I saw that.
excited that you have these conversations with your patients, that you ask permission to talk about this with a minor, a parent. And I'm sure that parents are thrilled that you have this discussion with their child, and probably they have a hard time talking to their children about this, and having a healthcare provider engage in this conversation is very meaningful. So I'm overjoyed about it. I think it's wonderful.
Thank you so much. I did want to share too that 30% of teens say their parents have never had a conversation with them about sex. And it just breaks my heart. So where are they getting their information? Where are they getting their education? And here again, we could talk about programs in schools and where they're lacking and where they're not being successful. They need us. And I feel so responsible for sharing this information with them. And it was really great to see you nodding your head as I was speaking. I have such admiration for you and what you do and what you know. So I feel very validated that I'm on the right track. Thank you.
Absolutely. I'm over the moon right now.
Aw. All right, Spring, you're next.
Well, first I want to say that HPV is like my favorite subject. So,
Oh,
Yes.
I feel like I've picked the best 3 people that I could have picked for this.
So I probably read more literature on HPV than anything else. So it was hard to pick which angle I wanted to come at it with, like transmission, pathogenesis, like there's just so much. So I found an article that kind of put it all together, but it was written for primary care physicians and physician's assistants. And it was to bring awareness to the fact that primary care physicians and physician's assistants are not screening or discussing HPV-associated oropharyngeal cancer with their patients. So it kind of breaks everything down together and in the end wants to bring more awareness to primary care physicians. But I think the good thing about it is it just is one more way to show that we are really the front line. We are the ones that need to be doing this because they're not getting it at their physician's appointments. So that's why I chose this particular one. The title is HPV-associated oropharyngeal cancer, and it was written by Trina Sheedy and Chase Heaton. They are both, one is a senior physician, and the other is an assistant professor at the University of California in San Francisco. So, and they work in the Department of Otolaryngology. Okay.
Otolaryngology.
Yeah. That's really hard. Anyway,
Yeah.
It's the head and neck.
Together we can do it.
Yes, yes. So they start with the transmission, and they discuss, which is very interesting because the transmission in the anogenital area requires some kind of microabrasion for the virus to enter. However, the epithelium of the tonsils is reticulated, which allows for egress of lymphocytes, and at the same time allows for ingress of the HPV virion. So trauma is not necessary for HPV to enter into the cells of the tonsils. Once the virus enters into the cells, they express different genes. The oncogenes E6 and E7 are the ones that are responsible for transcription, replication, and inhibiting apoptosis. And most of the infections, like Kathryn mentioned, will clear the body in 1 to 2 years. However, something that's really interesting is that men take almost twice as long to clear HPV from the tonsil, the oropharyngeal area, as women. And I actually reached out to kind of a mentor of mine, and she has a lab that she studies HPV-associated oropharyngeal cancer. And I asked her, I said, what's the deal with this? I wanted to add some commentary to explain it. And she said, we don't know. We have no idea why this happens with men. It's an ongoing area of study, but it is a problem and it's an issue. And that's why we see so much oropharyngeal cancer in men. So the best she could say was that somehow they have a decreased immune response that is not able to clear HPV as well as women. Men are, of course, much higher risk. So the HPV positive oropharyngeal cancers also don't have one particular mutation. It's a bunch of different mutations that end up as the same cancer. So it's like when you see the mutations in breast cancer, the BRCA1 and BRCA2 and all those kind of things, that we don't have a particular one that they can pinpoint that causes the HPV virus to end up being cancer. They just don't know. The only thing they know is that the E6 and E7 oncogenes, they suppress the tumor suppressor. So they actually degrade the tumor suppressor cells. I wish I could speak today. P53 and PRB, which means absolutely nothing except for P53 is very well known for being the reason that things become cancerous. Anytime it's degraded, it's called the guardian of the genome. And so it helps protect you and stops the cancer cells from reproducing over and over again. So they definitely degrade that. And they really know that that's one of the things, but they don't know why it happens with some people and why it doesn't with others. And another thing that they mention is that the anatomy of the oropharynx is conducive to cancer development because tonsils have crypts, and that increases the epithelial surface by 700%. So that's pretty significant. And that usually the primary tumor is deep within the tonsils. So by the time that we can actually palpate it, it's usually metastasized to the lymph nodes. Usually you can't tell that it's there until it's metastasized, unfortunately. And so historically, women had the highest burden of HPV-associated cancers with cervical cancer. But currently, the most common cancer caused by HPV is oropharyngeal cancer occurring in men. Right now, that's the number one. So patients that do have it generally don't have any symptoms. They don't complain about anything. They say they feel well. You don't even know that there's an issue at all. And then they talk about screening. So a screening tool is just not feasible, like something like a pap smear or something like that, because of the anatomy of the tonsils. So currently, there's no screening tool for HPV-associated oropharyngeal cancers. And the only thing that we really have is prevention, which is the vaccine. And then, of course, treatment. And treatment varies, like Kathryn was talking about. Sometimes it's chemo, sometimes it's radiation, sometimes it's both. Just depends on what stage the cancer's in by the time that they find it. And so the one really interesting part of this, which is the whole point of it, really is that they looked into several surveys that were done and found that there's a huge knowledge gap, not only in physicians, but also in lay people as well. So they surveyed 308 healthy adults, and only 40% had heard of HPV, heard of it ever. And of those that had heard of it, 33.5% were unsure or did not think it was common among sexually active adults. And only 47% identified HPV as a risk factor for head and neck cancer. And that's just in your regular lay person. And in another survey, same thing, regular lay people, they thought HPV infections were rare in men and thought that HPV could be cured with antibiotics, both of which are false. And so then they did a survey of pediatricians, primary care physicians, and OBGYNs. And they said that they lacked awareness of the primary tumor site, the higher prevalence in men, the sexual transmission, and the ability of the vaccine to prevent oropharyngeal cancer. And due to this, they don't usually discuss it with their patients as far as HPV-related oropharyngeal cancer. The whole point of this whole article was to bring awareness to primary care physicians and physician's assistants, but I think it's applicable here because I don't think most hygienists, dentists have this discussion with their patients about the association of HPV with oropharyngeal cancer. I think it's lacking in dentistry as well, which is super sad since we are the ones that should be screening these patients for oropharyngeal cancer.
I all those stats, they were jaw dropping, I should say. And if this whole podcast, I just feel like it's such a great example of how we are more than a scaler in our hand. We are so much bigger than that. That is a scary set of stats that you just gave.
Absolutely.
Kathryn and JoAnn, do you have anything to add or comment?
I would just like to comment that I am such a big fan of spraying and how all of those statistics and explanations are so easy for you. You have such a deep, deep knowledge of it. And where I try to super simplify things, I think that it's all simple for you. And I just love the way you explained it. Thanks.
Thank you. It's so funny because I have a really hard time simplifying things much more than I don't have that talent like you do.
I think it's also important for people to appreciate the pathogenesis and the transmission. And sometimes we gloss over the important information. I think you explained it really well.
Thank you. The one thing about transmission, though, and I just wanted to mention this, I don't have any, there are studies to back it up, but it isn't in the study that I used. But my friend that studies HPV isn't just a sexually transmitted disease, and I don't think enough people understand that. It doesn't happen often that it gets transmitted any other way than sexual, but it does happen. And I think there's a misconception about that. For some parents, they think, oh, well, my kid's not sexually active, this isn't a concern, but it could be potentially. So that's kind of weighs heavy on my heart sometimes too, because I don't think parents understand that their kids are at risk, even if they're not having sex sometimes.
Can I ask about some of those modes of transmission that are not sexual? I mean, is this like hands contracting it and then you're putting your hands to your mouth kind of thing?
I don't want to scare y'all too much. with this. But yes, it is fingers. It is actually currently we don't have any disinfectants that kill HPV off of fomites. Cavi wipes do not do it. They live on, think of intravaginal ultrasounds and things like that. They've been found on that after use, even with a barrier. So it can be transmitted that way. It has been found on toilet seats. Let me just say that probably doesn't happen very often that someone transmits it that way, but it's there and it can happen. It also can be transmitted from mother to child in utero and during birth. So your baby could be born with it, which is concerning in and of itself if you have it and you give birth to your baby. And it's not just if you have a vaginal birth, it can happen cesarean as well. And like I said, these things don't happen nearly as much as sexually transmitted, but there is documented cases and it's not just one or two.
I'm very concerned that it is not killed by a Cavi wipe. My brain has shut down since you've said that. I'm like, what do I do? How do I clean my stuff now?
I know I've read so much literature on it. My brain explodes. And every time somebody tries to talk to me about it and they're like, oh, it's not a big deal. I'm not having sex or my kid's not having sex. I'm like, there's so much more to it.
Steve here from Elevate Oral Care. Is your office prescribing a 5,000 parts per million fluoride toothpaste for high-risk caries patients? Are you sending them to the pharmacy? You may be sending them into an expensive and confusing maze of products, and potentially leaving them with only a few weeks of treatment rather than a supply that will last the whole time between recall appointments. Also, many pharmacy brands provide 1.8 ounces of prescription protection, a supply that will run out in as little as a month and a half, and cost as much as $42 a tube. In a recent survey, 80% of pharmacies only carry this small tube in a gel form. That requires a second brushing with regular toothpaste for plaque and stain removal. 6 months of treatment at a pharmacy can cost as much as $160 for your patients, while you can save them money by dispensing a 5,000 parts per million fluoride product. Eliminate this non-compliant maze and learn more by contacting us at elevateoralcare.com to schedule a lunch and learn with one of our educators. You can click on our staff meeting buttons located throughout our website. We look forward to working with you.
This is where we talk to our patients about strengthening their immune system. So we talk about sleep and we talk about nutrition and we talk about exercise and water and fresh air. It all contributes to improving and strengthening our immune system because we don't have those other protections. We have to have great gut microbiome and oral microbiome and the whole thing. I'll bet JoAnn knows a whole lot more about this than I do. Give me something, JoAnn.
No, but I agree with you. I think being healthy is important.
So I will mention this. There are a lot of studies that indicate that folic acid does help clear HPV infections. So you're right. Nutrition is certainly a big, big, big thing.
I'm going to add this to my course for next week. BT dubs. Thank you for that information. All right. So that leaves us with JoAnn. What do you have for us?
So I have to tell you that the article I want to talk about is a study that was conducted by one of our thesis students, Toni McElroy from Florida. And she, along with my colleague, Dr. Ellen Rogo, and myself, did an experimental study of Florida dental hygienists. And this article will be published in the Journal of Dental Hygiene. It should come out in either the April or June edition. And Toni presented this in June at the ADHA annual conference last year and won the Sigma Phi Alpha Journalism Award for this study. So I'm very proud of her. And what we attempted to do was assess the knowledge of Florida dental hygienists in terms of their understanding of HPV and the risk factors and their willingness to talk with patients about HPV and vaccination and all of the issues associated with it. And so what we learned was that most dental hygienists were very aware of the need to perform an oral cancer examination on their patients. They had some knowledge about HPV, but not full knowledge about HPV and risk factors, similar to what Spring just mentioned. They had concerns about talking with their patients about this particular condition and were quite reluctant to do so. Very similar to what Kathryn and Spring have already talked about. And so one of the things that we have recommended and things that they asked for was continuing education programs that would teach them to perform a better comprehensive oral examination and how to converse with their patients about HPV and vaccination and how to perform a sexual history. So we learned a lot from working with these individuals and conducting this study. And I look forward to the manuscript actually being published. So for the students out there, there's a lot that you can learn by conducting research among your colleagues. So that's the first thing. But when we did this study, I then looked up to say, well, surely other healthcare providers, maybe they have more expertise in this area or feel more comfortable talking to their patients and have more exposure to taking a sexual history. Well, guess what? In the March 2017 issue of the American Academy of Family Physicians, there's an editorial in there by Dr. Donna Sweet where she talks about the fact that even though family physicians know that they should talk to their patients about sexual health and take a sexual history, and that it's part of their everyday work that they should do, and though they know what to ask, many of them are uncomfortable asking intimate questions about a patient's sex life. And Richard Pesagno, who is a nurse practitioner, wrote in Nursing in 2013 that nurse practitioners shouldn't be embarrassed to take a sexual health history, yet, unfortunately, many of his colleagues have limited knowledge about how to take a sexual health history and are really uncomfortable taking a sexual history and talking about this very important health aspect of people's lives. So I will share with you that when I talk about this with my colleagues in dental hygiene, most of them say this is not their job and they are not going to talk to their patients about this. And how should they or would they enter into this conversation? Unlike our good friend Kathryn, who has no problem talking to her patients about this, people do. So when I was researching this, because I thought, well, we know now that we have research that says that people are uncomfortable talking about this. How would we do this? I happen to actually be very fortunate to have a daughter at the time that I was looking into this who was going through medical school. And I asked her, how did she learn about this? She was learning how to take a sexual history. And I asked, what was her guidance? So there is a wonderful document I want to share with you for the rest of my part of this presentation. It comes from the U.S. Department of Health and Human Services, the Center for Disease Control and Prevention, and it's called A Guide to Taking a Sexual History. And I share this with my colleagues all the time. So you can download this document. Just go on the CDC website and you can download this document for free. And within the document, it talks about the 5 Ps that you can ask patients about. And the 5 Ps stand for partners, practices, protections from STDs, past history of STDs, and prevention of pregnancy. And it goes through each section and gives you questions, sample questions that you can dialogue with your patient. So I'm not suggesting that we have to ask all of these questions for our patients, but I'll give you a couple of examples that you might want to customize this guide and think about what questions might be most helpful. Now, first of all, we don't have half an hour to take a sexual history because we all know we worry about time is such a big thing. But let me give you a couple of examples of the questions. One might be, are you currently sexually active? And if no, have you ever been sexually active? And in recent months, how many sex partners have you had? And are your sex partners men, women, or both? So these are just examples. It doesn't mean, again, you have to ask every question. These are just some examples. And this dialogue goes on and it gives you, I'm now going to be more explicit about the kind of sex you've had. What kind of sexual contact do you have? So is this genital, anal, or oral? So, some of you may be thinking, oh my God, this is very personal. And how could I possibly ask my patients these questions? But when you think about it, we're leading to the conversation about HPV and protection and vaccination. So as Kathryn said, she's very comfortable talking about relating this to the oral examination, to the risk of oral cancer and the risk of HPV-related oral cancer. So you're making the connections of one type of activity to a head and neck cancer. So the whole time when you're seeing these kinds of questions and thinking, I could never do this, you have to remember several things. It's not about you. It's about your patient. So, when I do this course, this continuing education course, and I watch everybody start out looking very normal, and then they see the skin color change to pale, I'm going to pass out, or bright red, I'm so embarrassed. I talk about the fact that it's not about you and how comfortable you are. It's about your patient. And when I talk with my patients, most of them are actually quite comfortable talking about this. And they're very grateful that somebody is talking about this in relation to cancer, in relation to protection, in relation to vaccination, and all of these things. And so one of the next questions dialoguing with the patient is, do you and your partner use any protection against sexually transmitted infections? Now, the CDC all talks about sexually transmitted diseases, and we know our newer language is STI versus STD. So again, you customize this. And what kind of protection are you using? And you can just ask, how often are you using that? Because as Kathryn said, some younger individuals don't use any protection at all, or they use it every once in a while, not regularly, because younger individuals tend to think they are not as vulnerable to infection, or it won't happen to me. Maybe that would happen to somebody else, but it's certainly not going to happen to me. So we have to talk to them about their risk. So that's, another example. And then they have other ones, have you ever been diagnosed with a sexually transmitted infection? And when was that? And what treatment did you have? Did you seek treatment for it? So these are just some examples. Have you been tested for HIV or any other sexually transmitted infections? These are just examples, And then the last one, of course, is pregnancy. Are you trying to get pregnant? Have you talked about pregnancy? Are you practicing any form of birth control? So as you can see, none of these questions are really overbearing, but if you're not used to them, they feel extremely personal and they seem difficult to ask. But if you've attempted to do this and you have tried this a few times, you can become more comfortable. And in my course, I talk about the idea of gaining experience with this. If you haven't ever asked questions that seem this personal, it's helpful if you practice. And you can practice with your staff members. You can practice at home. You can practice in a study club and gain familiarity with the kinds of questions. And then you can translate these questions to the next steps and talk about HPV vaccination and promote the idea of further protection through vaccination. So one thing can lead to another. The next thing you can talk about is maybe doing an oral cancer self-exam at home. So you can see how one thing leads to the next thing, which leads to the next thing. And it's all about prevention. What we are preventive health specialists, and this is following very well within our role as preventive oral health specialists. So I will tell you that it starts out where we think about ourselves and how uncomfortable we are, but with a little bit of experience and a little bit of focus on the patient, we can become very accomplished in this role of taking a sexual history.
I wanted to just say there were two things that you said. It's about the patient and not us being uncomfortable. And I say this a lot with other things, especially like infection control. Like your patient didn't ask you not to do the infection. They just asked that you don't get them sick. So like we have to honor our patients, like, and do what's right for them, even though it's uncomfortable, icky. And I do not enjoy that conversation that you just described to us. I've had to have it and it's a little icky. And my question to you is about the questions. So the questions cannot be first on a form, like an entry form or a patient health history. So then maybe I can just follow up to some of the questions or have a bigger, broader conversation until I get a little bit more comfortable asking those very specific things.
So I recommend that we modify our health histories and put some of these questions right on our health history form, just like we have other questions about cardiovascular disease, or sometimes we have questions about recreational drugs now and alcohol use and whatever else. We can have questions about your sexual health practices. And we're not accustomed to this because we don't think about it. But if they were right there on the health history, and this is our normal practice, and we're just going to follow up with a few questions about this, it would be the norm. And, you know, we have questions about pregnancy and other questions, and that's our norm. This would just be your sexual health practices. And if we had it on our health history form, and some patients would say, well, how is this related to, I just came to have my teeth cleaned? You know, it sparks that conversation. We can segue right into how this is related and have that conversation.
So, JoAnn, is that study already, when is it supposed to publish? Because I think I've read it. Is it online?
No, it's not yet out yet. It should come out either in the April or June edition of the Journal of Dental Hygiene this year, 2020. We are waiting for it to come out.
So I have it saved to read then on my PubMed, like collections under HPV, because I saw it just the other day. And when you said that, I was so excited because I thought, oh my gosh, I know this one. But I think that it's amazing and that we should definitely be having these conversations, and putting it on the health history is definitely probably the best way to ease into that, because I don't think that it will be overwhelmingly accepted by most hygienists. As I've mentioned HPV educations in the past, just in passing, and most of them are like, that's not for me, that's for the physician. And as my paper, it clearly indicates the physician is not, you know, talking about it as far as oropharyngeal cancer goes. So it's definitely our job. So I do like that idea. But the other thing I wanted to mention is when we talk about safe sex and using condoms and things like that, it's important to note that condoms don't prevent HPV transmission. And people don't understand that either. So that's another thing that we have to talk about to them as well, I think.
What prevents?
Yes.
I'm so concerned. So there's HPV everywhere now, and I can't protect myself.
Yeah, don't think about it too hard. It's everywhere, and people don't understand that. And And this is just like the tip of the iceberg, to be perfectly honest with you. If you really, really like dive into it and study HPV, it's mind boggling. And they're still studying it. They still don't completely understand it. It's crazy.
All right. And Kathryn, anything that you want to throw in here? I don't even know what to do with myself right now.
Like Spring said, it's really overwhelming. And I think we owe it to our patients to start this conversation. We need to let them know that they're not safe. They are at risk. All of our patients, we're talking about youth right now, but it's all of our patients. And it's not just all of our sexually active patients. Like Spring said, we're all at risk from multiple sources, from skin to skin contact and from surfaces. We just have to do the best we can. And we are not doing the best we can as practitioners, and we're passing the buck. And as Spring's study showed, physicians and nurse practitioners, nurses, they're not doing this either. Nobody wants to touch this topic because they're uncomfortable. But we have to elevate our identities for ourselves so that we can elevate our identities for our patients and for other practitioners, because we're entering into this world of oral systemics, and we know the connection between the mouth and the body. Physicians need to understand our value. Physicians like Bale and Doneen talk about how important dental hygienists are in the connection with cardiovascular disease and periodontal disease or endodontic disease. Well, other physicians need to realize that too, and we need to lead the way. The head and neck are our region, and we need to get over ourselves, like JoAnn said. And it doesn't matter if we're uncomfortable. I was uncomfortable at the beginning too. I'm still uncomfortable sometimes. And I really encourage my patients to ask me questions. I open the conversation and I ask them to ask me questions along the way. And we both learn through that. We all learn through that. So I just think JoAnn's information was mind-blowing. So was Spring's. It's a huge conversation, and it's time to step up and realize that we're not teeth cleaners. That's not our job. We're healthcare practitioners, and we have a huge responsibility for the lives of our patients. And I take that very seriously. I know y'all do. I know that the majority of dental hygienists do understand that. And we're just helping to clarify the next steps to take. I'm super excited to be part of this revolution.
And I just want to tell all the hygienists out there that are always wanting to be respected, and I'm not just a tooth cleaner, step up and screen people and talk to them about HPV. You want to be respected? Then do it. Don't sit there and go, oh, I'm going to clean these teeth and I want people to respect me and all this kind of stuff, and not step out of your comfort zone. I mean, you can't serve your patients in a better way than to help screen them for a potentially deadly cancer. I'm sorry.
No, I'm glad someone else gets on that soapbox as much as I do. I just feel like, just for the students, this being a student focus, when I was a student, my dopamine release or that I got was when I popped that big chunk of calculus off, right? And now I am getting that same level of gratification and like that high when I talk to a patient about something that no one has ever talked to them about before. And they say, God, I learned so much when I come to my appointments with you. Or no one's told me that. I'm going to go and look into that some more. It is literally the thing that keeps me going in life, because I'm able to make some major differences for my patient. And it has nothing to do with when I pick up my scaler. It's different than what you learned in school. It's different than what our national boards and our clinical boards are based on, but it's bigger than that. And it's going to be what makes a difference, or how hygienists make a difference in the lives of our patients.
So I have two things to comment about this. And one is, when we first learn how to do anything, we are uncomfortable and unsure of ourselves. And when we first learned how to identify our instruments, we didn't know what we were doing either. We couldn't tell a scaler from a curette. We couldn't tell an anterior curette from a posterior curette. And it was hard. But eventually we learned to distinguish one thing from another and how to use them. And the same holds true for this. We're not used to this, so we're uncomfortable. But once we start learning this information and how to do it, we become more comfortable. And this will be just like everything else that we do. We will become really refined and excellent at how to do this. And the second thing is our students have more varied life experiences than we have had. And it is the students who tell me how vital it is that we do this and we ask these questions and we talk about this with our patients. So when I teach these courses and students are in the room, they are the ones who are telling our licensed dental hygiene colleagues that it is essential that they take on this role and talk to their patients about taking a sexual history and talking about HPV and talking about risks and talking about vaccinations and all of these things that we've been addressing, because their life experience is so different and they have had challenges and they have had exposures to STIs and they have had maybe cervical cancer or something that has given them pause, given them a new way of looking at something that maybe we have not had in our life experience or less of in our life experience. And so I allow them time to talk about their experience, and they're the ones who champion this and say, don't be so afraid of yourself, or get over yourself and do the right thing, do what needs to be done. Because when we do hear the statistics that Kathryn and Spring have talked about, it is not only insightful, it's impactful. And the American Cancer Society has said that in 2020, we can expect over 53,000 people to have new cases of oral and pharyngeal cancer, and almost 11,000 individuals will die. And 70% of those individuals will have an HPV-related oral and pharyngeal cancer. And we have to stop that. We have to change those statistics. And only we in oral health care can do that. We cannot say, well, I won't do this because a physician will handle this, or I won't do this because a nurse will handle this, or I won't do this because the dentist will handle it. No, this is our job. We are the preventive oral health specialists. So go prevent something, prevent people from dying, prevent people from getting this cancer.
Preach it, preach it, preach it. Well, I am so happy that I was able to have all three of you on. I am sure every person took multiple pearls from this. I have a list over here of things that you reminded me about and then built on my knowledge on. So thank you so very much. I would love for us to take a minute now to give our listeners your contact information. So if they have any questions or they want to follow up with you, where can they do that? So I'll start with you, Spring.
They can contact me via email at springhatfieldrdh@gmail.com.
Perfect. Kathryn?
I can be reached at Kathryn, Kathryn, at PerioLinks.com. It's PerioLinks.com.
Awesome. And JoAnn?
I can be reached at GUREJOAN@isu.edu.
Awesome. Thank you all so very much for taking your time. I am so grateful that you are giving us this time and this hour and this level of expertise. It means more than you will ever know. So thank you again for coming on. Y'all are the best.
Thank you.
Thanks.
you. It was an honor. Thank you.
We hope you guys enjoyed this roundtable. Thank you to our guests for bringing all their advice and their research that they found for us. And again, follow us on Instagram, follow us on Facebook. You can always go to our website at tale2hygienist.com. We would love your feedback. And don't forget to share this episode and rate and review us on any of your listening apps.
Thanks, everyone.
Bye, y'all.